Okay, the diagnostic studies for renal section, starting with the urinalysis. This is a widely ordered laboratory procedure for basic screening purposes. It evaluates the kidney's ability to selectively excrete and reabsorb substances while maintaining fluid balance. Some of the things we might see: specific gravity is a reflection of the concentration ability of the kidneys. So the higher the specific gravity, or out of the ordinary high level, is indicative of dehydration. Urine protein is another indicator of renal disease. So urine protein greater than a trace may be indicative of renal disease, or it may just be a benign process going on. Glucose in the urinalysis is used to check for diabetes. Ketones indicate impaired carbohydrate metabolism. This may occur with dehydration, vomiting, or diarrhea. Nitrites and leukocytes are tested for bacteriuria or UTI. Urinalyses are often done on annual physical exams, commonly with patients admitted to the hospital, such as before surgery. We need to collect about 15 milliliters in a clean specimen cup. The sample may prefer early morning. If it's not going to be taken to the lab promptly, it may be refrigerated. This might be if a patient was collecting a UA lab at home. Note on the specimen paperwork that if there is blood, if the female is menstruating. Assess medications that the patient takes, their fluid status, and foods that might affect the urinalysis results. 24-hour urine collection. For this collection, you need to ask the patient to void and discard that first voiding, and that starts the time of the 24 hours. All urine that the patient produces is collected in the sterile brown rigid containers that are light resistant. They are also kept on ice and kept in the patient's room or bathroom for the 24-hour time before they are collected and transported together to the lab for the analysis. Any urine that gets dumped accidentally or lost invalidates the data for the 24-hour specimen. So it's helpful to have signs up in the hospital facility as far as the start and stop time. Things that can affect the 24-hour specimen: excessive consumption of meat and strenuous exercise 24 hours prior to the test. Creatinine clearance is a part of the 24-hour collection. Creatinine clearance determines the rate at which the kidneys are clearing creatinine from the blood, so this helps to determine glomerular filtration rate or renal disease. Total protein is another item that is measured with the 24-hour collection. A clean catch midstream is used when we are trying to look at possible infection with a patient. So they need to clean very carefully around the urethra with the male and the female, and then they start voiding into the toilet and then move the collection cup underneath the urine stream to collect the midstream. Obtain that midstream sample prior to starting antibiotics. Okay, now again with creatinine, if we're looking at doing a serum reading, remember creatinine is a byproduct of muscle and is excreted by kidneys. If 50% or more of the nephrons in the kidneys are destroyed, the serum creatinine levels begin to rise. A normal creatinine should be between 0.6 to 1.3, depending on what lab manual you're using. Older adults and women may have decreased values due to decreased muscle mass. The amount of creatinine generated in an individual is proportional to their mass of skeletal muscle present. It remains fairly constant unless there is massive muscle damage resulting from something like a crushing injury or a degenerative muscle disease. Chronic renal insufficiency creatinine levels are 1.5 to 3 milligrams per deciliter or higher. Chronic renal failure presents at levels greater than 3. The serum creatinine level has much the same significance of BUN but levels tend to rise later, therefore elevations in creatinine suggest the chronicity of the disease process. The creatinine may be affected by medications, antibiotics, ascorbic acid, methyl-dopa, aldimate, and lithium carbonate. If they're going to be having the creatinine test done, you might suggest not eating red meat the evening before the test if possible, avoiding strenuous exercise for 8 hours. The creatinine, unlike the BUN, is not going to be affected by the hydration status. The BUN then is the blood urea nitrogen. Its norm is approximately 6 to 20 milligrams per deciliter. We do need to assess the hydration status, which can affect its results. Dehydration, vomiting, diarrhea, digested blood, or pre-renal and renal failure may increase BUN. Urea is a non-protein nitrogen compound formed in the liver from ammonia as an end product of protein metabolism. So urea is ultimately excreted by the kidneys. BUN levels reflect balance between the production and the excretion of urea. Critical values include values anything greater than 100 milligrams per deciliter. BUN can also be caused by a high protein diet, and you may also see the BUN creatinine ratio, and that's typically 12 to 1 to 20 to 1. The GFR, the glomerular filtration rate, is considered the most accurate means of detecting changes in kidney function. Remember, that's how they classified the stage of chronic renal failure. So the eGFR is calculated based on the serum creatinine, the age, gender, in some cases race, and normal would be about 125 milliliters per minute. Uric acid is the end product of purine metabolism. Purine sources include organ meats, legumes, and yeast. Uric acid is filtered and absorbed and secreted by the kidneys and is a common constituent of urine. A value greater than 13 would be critical, and there are some slight differences between the female and male. The male typically has a slightly higher uric acid. Uric acid may also be elevated in gout and is associated with the formation of kidney stones, so be aware of that if your patient is presenting with those type of symptoms. Okay, we'll get into some of the imaging tests now. The renal ultrasound is a non-invasive test that's used to get images. It's done by applying a conductive gel to the skin and placing a probe on the skin. Sound waves are recorded on the computer as they are reflected off of tissue. No special preparation is needed before a renal ultrasound. The other type of ultrasound for this area would be the bladder scan, which also uses an ultrasound image that can be used to obtain information about residual urine. Nurses can do bladder scans on the floor. You need to obtain readings in milliliters and record the largest amount that you get with your machine. Report residuals of greater than 100 milliliters. X-rays and other imaging studies. Renal scan is where a radioactive isotope is injected intravenous and radiation detector probes are placed over the kidneys to monitor the activity in the kidneys. The radioisotope distribution in the kidneys is scanned and graphed. Renography simultaneously tracks the rate at which radionuclide flows into, through, and out of the kidneys. This may detect thrombosis or stenosis of the renal artery. It may also show tumors and cysts on this study that appear as cold spots. Ask the patient to drink several glasses of water prior to the test. Have them void and obtain a weight. After the procedure, we need to increase their fluid intake to help eliminate the radionuclide from the body. Assess for medication use within 24 hours, such as the use of ACE inhibitors or beta blockers. It is performed in the nuclear med department and takes about 60 to 90 minutes. Instruct the patient not to touch their urine after this testing. CT scan of the kidneys allows evaluation of kidney size, tumors, abscesses, renal masses, obstructions. Contrast dye may be administered orally or intravenous. Assess the patient for allergies to iodine, X-ray contrast dye, and seafood. We need to obtain results of the BUN and serum creatinine prior to the study, and the patient may be NPO 4 hours prior to the test. Laxative or enema may be used to remove gas or feces from the bowel, and oral hypoglycemic agents are contraindicated for use with the iodinated contrast. If your patient is on glucophage, that is going to be discontinued on the day of the test, and they should not take it for the next 48 hours because this would interact with their oral medication. Post-test, tell the patient to report allergic reactions such as rash, itching, headache, and vomiting, again to increase their fluid intake to promote excretion of the dye. The procedure takes about 30 to 60 minutes, and the patient may experience a warmth and salty or metallic taste or even a headache after injection of that contrast medium. MRI. For the MRI, patients are assessed for metallic implants such as pacemakers, clips on brain aneurysms, body piercings, or shrapnel anywhere in their body. We should remove transdermal medication patches prior to entering the MRI field. Assess patients for claustrophobia. MRIs may detect glomerulonephritis, hydronephrosis, masses, lesions, renal vein thrombosis. It may be done with or without an IV contrast medium, and the patient will need to lie still during this exam. The IVP, or the intravenous pyelogram, is done to visualize the entire renal tract to identify abnormal size, shape, and function of the kidneys, or to detect renal calculi or stones, tumors, or cysts. This is often done in children to see if they may have an abnormal backflow of urine, which is vesicoureteral reflux. The contrast medium concentrates in the blood and is filtered out by the glomeruli and passes out through the renal tubules and is concentrated in the urine. Renal function is reflected by the length of time it takes the contrast medium to appear and to be excreted by each kidney. A series of images is taken at 1, 5, 10, 15, 20, and 30 minutes following injection into the system. We need to assess the patient for allergies such as seafood, iodine, radiologic contrast dye, and assess the renal and fluid status. Again, the oral hypoglycemics such as metformin, glucophage should be discontinued the day of and 48 hours after this procedure. Bowel preparation, laxatives, enemas, or suppositories may be needed. No food 8 to 12 hours prior to the test, but clear liquids are probably allowed. Report reactions to contrast medium such as tachycardia, itching, rash, or difficulty breathing. During the IVP, there may be a device that is wrapped around the abdomen, which compresses to keep the dye in the kidneys. And then the renal arteriogram. This is used to detect renal artery stenosis, thrombosis, or embolism, tumors, cysts, or aneurysm, or when we're evaluating a patient with primary hypertension. A contrast medium is injected through a catheter into the femoral artery that's threaded up to the aorta and into the renal arteries. Prior to this, we're again assessing for the allergies, and also since this is going into an artery, we need to assess their coagulation studies prior to the test. Also, discontinue the oral hypoglycemics the day of and for 48 hours afterwards. NPO typically for 8 to 12 hours. During this procedure, cardiac rhythm is monitored, and after the angiogram, we need to monitor the site from where the catheter was placed. So usually this is going to be the femoral artery. Also assess peripheral pulses from that extremity, monitor the urine output, and their activity is usually going to be restricted for at least a day or so, and usually they're on bed rest for 4 to 6 hours after the procedure to ensure that that artery site clots off. The arteriogram or angiogram may also be used as an interventional procedure with infusion of thrombolytic drugs if there is a clot occluding an artery, or it may be useful for a stent placement into the renal artery. Cystoscopy, so these are going to be urologic endoscopic procedures. With cystoscopy, renal tumors can be removed, tissue biopsies may be obtained, ulcers or bleeding sites within the bladder can be cauterized, a stent may be inserted to facilitate urinary drainage past an obstruction, and ureteral or urethral strictures can be dilated. Also, a retrograde pyelogram may be done by instilling contrast dye into the bladder. Patients that are undergoing cystoscopy are generally NPO for 8 hours prior to this procedure. They will have local or general anesthesia. We do need to assess for a history of cystitis or prostatitis, assess their urinary patterns, assess for complications following the procedure, including hemorrhage, bladder perforation, and urinary retention. They may have some discomfort, so post-procedure heat may be applied to the lower abdomen, or they can take a sitz bath to relieve pain or muscle spasms. We need to increase their fluid intake and let them know to expect a slight burning sensation for the first day or so. Notify the physician for bright bleeding in urine or prolonged light bleeding, which should clear after 3 voids. Report any flank pain, decreased urinary output, abdominal pain, fever, or chills, and monitor the intake and output. A ureteroscope is a longer and thinner tube than the cystoscope, but it would be used in combination with a cystoscope to see beyond the bladder and into the ureters. Some ureteroscopes are flexible like a thin straw, and others are more rigid and firm. The CMG, or the cystometrogram, is a urodynamic testing of bladder function. It evaluates the motor and sensory function of the bladder with patients with incontinence or neurologic bladder dysfunction problems. It's often used to determine causes of recurrent UTIs or urinary retention, or to determine the type of incontinence. So to do this procedure, the patient is going to void, and then a special urinary catheter is inserted. Residual urine is measured and recorded, and then a measured quantity of fluid is instilled into the bladder, and the filling capacity and voiding pressures are measured. Tell the client the bladder will be filled, and during the filling, he or she will be asked to describe when they feel the first urge to void and the sensation of being able to delay urination any longer. This catheter is connected to a cystometer. It kind of also detects normal urine stream, which should be strong and uninterrupted. Bladder capacity for most people ranges from 300 to 600 milliliters, and most people start feeling an urge to void at greater than 150 and a need to void by 300 milliliters. Okay, renal biopsies may be used to determine the cause of renal disorders or to rule out cancers, and can be done a couple of different methods, either through a cystoscope, either through excising a wedge of kidney tissue, or through the skin with a needle biopsy. And these would be a percutaneous route with local anesthesia. Patients will be NPO for 8 to 12 hours. If a general anesthesia will be used, we need to note the pre-hemoglobin and hematocrit values and report anything abnormal. Clippers may be used for hair removal, and a sandbag under the abdomen may be used for positioning. For the percutaneous route, instruct the patient to take a deep breath, exhale forcefully, and hold the breath while a biopsy needle is inserted and rotated to obtain a core of renal tissue. If the percutaneous route was used, apply pressure to the site for 20 minutes to prevent bleeding. Increased fluid intake after the procedure is indicated, and We should report a decreased urination or burning on urination that the patient experiences. Usually the specimen is placed in a preservative, and we need to be especially cautious of assessing the biopsy site for bleeding, inflammation, or hematoma formation after the procedure.